My name's Dr. Christopher Rogers. I'm a physical medicine and rehabilitation physician. Been practicing in San Diego for more than 20 years. And I'm joined by my colleague, Dr. Mary Ambach, who's also a board-certified physical medicine and rehabilitation physician. And we'd like to thank you for taking time to join us today. Hope that you and your family are remaining safe and healthy during these challenging times. We are going to share some exciting new treatment options that we've helped develop for spine pain. Both Dr. Ambach and I are specialists in the area of spine care, having completed fellowship. And what that means is, after you graduate from medical school and decide what you want to do when you grow up, then you do a 4-year residency program. And we did ours in musculoskeletal medicine, physical medicine. And then after that, we decided, why not? We've already been in school for 28 years. Let's do one more year. So we do a fellowship year where we learn how to treat the spine non-surgically with more advanced techniques. So we're going to talk to you a little bit about how that's evolved over the past several decades that we've been doing this. Next slide. So as I said, I'm board certified in physical medicine and fellowship trained. And I'm founder of a group that we call the San Diego Ortho Biologics Medical Group. And orthobiologics is a big word that just means we use cells to treat sports medicine injuries and spine injuries. And I've been doing this for more than 2 decades. Dr. Ambach joined us more than a year ago now, and she's had, it says 12 years experience, but it's actually more than that now. I think we need to update this slide. And I met Dr. Ambach originally because we both like to lecture around the country when we were allowed to do that, when we were allowed to travel and lecture to doctors around the country and the world. And I was impressed by her academic expertise, and so had to bring her to San Diego. And she's published in medical textbooks. She'll tell you about some of the research she's conducting, and we'll get into that a little bit later. Next slide. So these are just some pictures from when we used to travel around the world and teach doctors how to do different procedures. And this is important because a lot of the techniques we're going to be talking about today are new. You don't learn them in medical school. You don't learn them in residency. And the way your doctor gets trained is by going to conferences like this and learning from fellow physicians. And there's a small group of us, there may be 500 around the world, that are specialists in regenerative medicine and orthobiologic treatments, but the field is growing very quickly. Next slide. And as I mentioned, we have contributed to the medical literature. We hear often that there really isn't anything published about stem cell care or platelet-rich plasma care, but that's not the case. As you can see, there are a number of textbooks, and we envision that these textbooks will soon become standard reading material for residency programs when they do start to have regenerative medicine residency programs. Next slide. And this is our office. So those of you who have been in Carlsbad near the flower fields, we built this office about 4 years ago, and we feel very blessed to be able to treat fellow San Diegans. I'm actually a native San Diegan, and really feel privileged to continue to work here and serve this community. Next slide. I knew when I started investigating PRP and stem cell therapy about 12 years ago, I knew that I needed a special place to allow me to do this work. And so we created this space to be not just comfortable, but also state of the art. So on the next slide, you'll see we have a procedure room where we have advanced equipment. On the right, you see a large piece of equipment that we use for imaging the spine. That's called fluoroscopy. It's a digital X-ray camera that allows us to see all the parts of the spine. And then on the left, you see a portable ultrasound machine that we use for looking at soft tissues such as muscles and tendons. Next slide. This is our lab. I'm actually in the lab right now because that's the only place I can hide out and not wear my mask. Dr. Ambach is hiding out in a different room, not wearing her mask at the moment. But otherwise, we do wear our masks in the office. But this is our lab, and you can see the equipment we use to process different tissues. So we use your own tissues. We use blood or bone marrow or fat tissue. These are tissues that are rich in different orthobiologics that have been shown to be helpful for treating pain and inflammation and for regenerating tissue. Next slide. And just to reemphasize that we take COVID very seriously, and we actually shut down the office for a little more than 2 months through March, actually through June. And since then, we do regular screening. So anybody who comes to our office has been screened by phone. And then if you come visit us, you're going to have your temperature checked, and we're going to screen you again. And if you have a procedure, we may do antibody testing. And then, of course, the office is disinfected between each patient visit. And then we have these really fancy UV lights, which, next slide, which have been shown to be helpful in decreasing the viral burden. Next slide, yep. So you get a sense of UV light. UV light, by the way, is not safe for your eyes or for your skin. That's why we get skin cancer. So we have to lock up the rooms in between patients. It only takes a few minutes to disinfect the room. Next slide. So in summary, we're going to talk about some of the common causes of back pain. As I told you, I've been treating the spine for more than 2 decades. I can honestly say in the thousands of people that I've evaluated, I've never seen 2 spines exactly the same. And so back pain is an exceptionally challenging part of the body to treat. It's different than a knee or a hip or a shoulder, which is a less complicated part of the body. And so we're going to talk about some of the things that we see commonly, although I have to say that each case is a unique, customized case. We're going to talk about platelet-rich plasma, or PRP. We're going to talk about some stem cell therapies, and then Dr. Ambach, who is our scientific nerd, she's going to review all the literature, not all of it, but some of the highlights of the literature, because we are an evidence-based practice. We're not going to practice any new treatment until there is some evidence that what we're offering is safe and that there's some efficacy data to support our recommendations. At the end, we'll take your questions and we'll answer all of them if time allows. If you have a specific personal question about your own personal health, just say that, put a message there on the Q&A section, which is on the lower right. Just say you'd like us to call you or send you an email and answer your question. Next slide. So the most common cause of back pain would be a simple strain of the ligament or the tendon. This is something that many of us have experienced. These are typically short-lived. Usually you'll recover within a matter of a month or a month and a half. Some of the more chronic causes of low back pain, something that might last more than just a few months, are some of the things that we're going to talk about today. So osteoarthritis, which is damage to the cartilage in the joints of the back. For example, I have my friend here helping me out, little skeleton, right? So you're familiar with the spine, and we're talking not just the low back, but we're also talking about the neck. But this pattern is repeated throughout the entire spine, where you have the bone, which are the vertebra, separated by the discs. And then in the back of your spine, you may not realize there are little joints that are hard to see here. They're about the size of a knuckle in your hand. So you can imagine 5 knuckles on either side of your lower back. And these joints have cartilage, which can become degenerated. And it's one of the most common causes of chronic low back pain, would be arthritis in the low back. So as I mentioned, you have the discs. I think most of you have heard about a herniated disc. That's where the jelly center of the disc would move from the center towards the periphery of the disc. And in some cases, it actually exits. It actually rips the outer fibrous portion of the disc, and that herniated portion can then put pressure on the nerves, like you see in that picture. And so those are common conditions that we might see. Unfortunately, as we age, the chance of the disc degenerating is very high. The disc actually has very few cells, less than 40,000 cells in a disc. And so it has no blood supply whatsoever. So unlike your skin, which has a good blood supply, or your muscle or your bone, which can heal very easily, a disc has trouble healing. And so it can be a common source of chronic low back pain. Next slide. And these are the joints that we were just talking about. We call them the facet joints, and they can become inflamed, or the cartilage can wear out, and that can produce chronic pain in the back. And that's probably about 40% of our patients with chronic low back pain. Next slide. So this concept of regenerative medicine is based on the notion that our body can heal itself, and something that's self-evident. We know that our body can heal. If you cut yourself shaving, or if you bruise yourself, you know that in a matter of time your body's going to fix it. But maybe most of us don't think about how that actually happens. Well, fortunately, a lot of scientists have thought about how that happens, and what we're learning is that it's our cells, and certain cells in particular, that are responsible for that regenerative capacity. Unfortunately, we lose some of that capacity as we age, or if you have a serious injury or an injury that's been going on for a long time, the body may be overwhelmed and unable to completely heal the injury. So sort of, you can think of these as a chronic wound, and these are painful and they can cause inflammation. So these are the kinds of things that we're talking about. Next slide. So I tell my patients, now I'm a farmer. So if I was a farmer, I would want to plant good seeds with fertilizer in the soil. And in the case of regenerative medicine, it's the same idea. The next slide will show you that instead of seeds, we use cells. So we're planting cells. They might be platelets, or they might be stem cells from the fat or from the bone marrow, or other types of cells. We use something called growth factor. A growth factor is a protein that is created by cells that stimulates other cells to proliferate and grow. It can also stimulate those cells to manufacture structural proteins that make up cartilage or make up tendon or bone. And then, of course, those tissues and those cells have to live in a space that's safe. And so scaffolds, which are proteins such as collagen, which you've probably heard of, can be used also as part of this regenerative medicine process. And that picture on the upper left is just a picture of your cartilage. So you see it's a very complicated structure. Under a microscope, you can see the cells in the cartilage, and then the bone with the holes in it where the blood vessels travel through the bone. So you can see there's good blood flow to the bone, but really no blood flow to the cartilage. Next slide. So we talked about this. What are Ortho Biologics? It's the name of our company. I chose it because it's bigger than just stem cells. It's bigger than just platelets. It's the whole universe of regenerative medicine. It's all those cells, all those growth factors, all those different molecules that we use to heal tissue. Next. And some of the common ones that you've heard about, we already mentioned: platelets, which are in your blood; stem cells, which are actually on the blood vessels in every tissue of your body. We just harvest them from fat or bone marrow because they're easily accessible. Growth factors, which are manufactured by those cells, and then some other biologics that you see there that we commonly use. Next. Platelet-rich plasma is probably the most common one you may have heard about. It's actually been around for several decades. Platelet-rich plasma simply is a concentrated solution of platelets and plasma, and this is obtained from your blood. So you can see we've centrifuged the blood, and you can see the centrifuge behind me. And when we centrifuge the blood, the red blood cells will settle to the bottom because they're heavy, and then the platelets will form that white layer in the middle. And then we can select from that layer and combine with plasma, which is the fluid component of the blood. And the fluid component contains enzymes, it contains hormones. Pretty much everything you had for breakfast this morning is floating around in that plasma. It's another good reason to eat healthy. And we can combine that plasma with the platelets to create a biologic that is therapeutic. Next slide. If you look under the microscope, these are what the ingredients look like. So that red layer at the bottom would be that big red blood cell, which, as you know, is for transporting oxygen in your blood. The white blood cell is for fighting infection. And then the platelet, which is that little purple guy, he's activated. See, he's got little tentacles sprouting out of him. At the end of each of those tentacles are little vesicles filled with proteins that are healing your tissues on a daily basis. And so when we treat you, we concentrate those platelets to the tune of about 9 billion of those. And by the way, those platelets are brand new. They're anywhere from 7 to 10 days old. So if somebody asks you how old you are, just say, well, what cell do you want me to talk about? So my platelet cells are only about 10 days old, and then they get replaced. And that's fortunate that your body makes about 10 million of these every second. Next slide. And they're producing these growth factors, the cell fertilizer that is so important for keeping the cells healthy and helping them grow and develop. These growth factors, of which there are thousands of them. I won't bore you with all the different kinds, but if you focus on one, the red one there, VEGF, vascular endothelial growth factor, This is a protein that stimulates your body to make new blood vessels. So you've had the experience of maybe you cut yourself on your hand and you'll notice a few days later it's red. Well, those are microscopic little blood vessels that your platelets helped to grow so that that tissue could heal. Next slide, please. And when we make PRP, it comes in different flavors. You can see we have cranberry on the left and we have lemonade on the right. And it really just has to do with how many red blood cells are in the PRP or how many white blood cells are in the PRP. So for example, if we're treating your knee arthritis, or say we're treating the arthritis in your back, we would use that lemonade flavor on the right that we call pure PRP, because there's very low concentration of red blood cells or white blood cells, which really have not been shown to, those cells have not been shown to be helpful for arthritis. The cells that are helpful are the platelets, and that's really what we're concentrating there. Next slide. So stem cell has become a very captivating topic for a lot of people. And the first thing you need to know is that we all have them. If you didn't have them, you would be dead. So it doesn't matter if you're 9 or 99, you have stem cells throughout your body, millions of them, if not trillions of them. And they are reproducing your tissues. They are able to replicate themselves, and they are able to differentiate into a different cell type. So they have the ability to become one of many different types of cells. And the stem cell, you're probably familiar with the embryonic stem cell, which was first discovered and studied in the early part of this this decade or last decade. You can see here in this fertilized egg becoming a ball of embryonic stem cells. Those stem cells, those embryonic stem cells, can become any kind of cell in your body. So you have over 200 different types of cells in your body, right? You have heart cells, brain cells, bone cells. So that embryonic stem cell can become any of those cells. We obviously don't use embryonic stem cells as a therapeutic for ethical reasons, and also because these cells can become a cancer cell. Those embryonic stem cells will differentiate. I think the next slide shows it. Will differentiate and make either a copy of itself or a new type of cell. That stem cell can become a new type of stem cell that we call an adult stem cell. Next slide. And one of the more well-known adult stem cells is something called the MSC. The MSC stands for mesenchymal stem cell. And the mesenchyme refers to those tissues that we as orthopedic specialists like. We like bone, we like tendon, we like cartilage, we like muscle. This MSC stem cell, it cannot turn into every type of cell in the body like an embryonic stem cell can. It's limited. It can turn into 6 or 7 different types of cells. And so this was discovered by our friend, Dr. Arnold Kaplan, who you see there standing between us at our last meeting. And Dr. Arnold Kaplan is a professor at Case Western, and he discovered this MSC in the bone marrow in the 90s. And it was very exciting because we thought, oh, great, now we just implant the cell and we'll just grow new cartilage because these stem cells will turn into cartilage cells. But that's actually not the case. Next slide. Actually, what they do, the way they promote healing, next slide, is they release these molecules. Some of them are growth factors. Some of them go by other names, such as cytokines or chemokines. But you can see those that on that microscopic image there, these little stem cells, these MSCs, are clinging to the very small blood vessels in all your tissues of your body. And when they sense danger, when they sense trouble, they become activated, and then they release these different molecules, which have been very well studied in the scientific literature and have been shown to stimulate tissue healing. They control inflammation. In some cases, they can even fight infection. So this stem cell is really not functioning as a stem cell. It's actually functioning as a medicinal cell. It's releasing medicines in response to any damage that it perceives in the tissue that we put it into. Next slide. So what kind of stem cells do you use? Next slide. So as I alluded to, the MSC, these cells, these stem cells are found in all tissues in your body, but we prefer to harvest them from either the bone marrow or from the adipose tissue. And we customize this to the patient. So in some cases, we may elect to use the bone marrow. In some cases, we may elect to use the adipose tissue. Obviously, if you're one of our Olympians or triathletes or some of our athletes who have no fat on them whatsoever, we can't use your adipose tissue. We would use bone marrow instead. But both of these tissues have been shown to be very rich in cells. Adipose tissue is more rich in the MSC than the bone marrow. Bone marrow contains platelets, which we already talked about. So there are pros and cons to each of these orthobiologics that we commonly use. Next slide. Now, one thing you may have heard of, some of you may have seen other seminars promoted, or if you were driving around the country, there are actually full billboards that I've seen where a clinic may offer what we call birth tissue. So these are cells that would be derived from umbilical cord blood or placenta or amniotic tissue. They're derived, from a natural childbirth. And although there are cells in those tissues, by the time they become processed and sterilized, those cells are essentially dead. So when these companies promote stem cell therapy by these products, we know that they do not contain any stem cells. No, they do not contain live stem cells. Furthermore, even if they did, we know that stem cells are regulated by the FDA, and the FDA does not permit the use of these donor tissues. You can use your own tissue. As your physician, we can use your own tissue, your own blood, your own fat, but we cannot use donor tissue until these products are evaluated for safety and efficacy, and they have not adequately been evaluated for safety or efficacy. And it's really not appropriate for doctors to be offering these treatments at this time. Next slide. And as I mentioned, not only have they not been tested for safety or efficacy, there's actually been several cases of patients developing bacterial infections and being hospitalized because of the product not being processed properly and contaminated with different types of bacteria. So we really just caution our patients to avoid using these products from other clinics. Next slide. So these are the current products that are compliant with current FDA guidelines. And I should mention there's a difference between being FDA approved, right? So every drug in your medicine cabinet is FDA approved. It's undergone scrutiny through safety and efficacy studies. Compliance refers to the fact that the FDA realizes that there's a need for patients currently. There's patients with arthritis who are not being adequately managed. There's patients with back pain who are currently not adequately managed. The FDA truly wants these biologics to be used in a safe manner. And so for low risk type procedures, for example, PRP or bone marrow or adipose tissue in orthopedic applications, the FDA has issued guidelines for that safety, and we are in full compliance with those guidelines. Next slide. And the reason they allow it, the question is, are these cell therapies safe? Next slide. The answer is yes, there are. There's good evidence in the published literature, scientific literature, showing that the use of your own cells, what we call autologous, is safe and shows better safety profile than many of the other things that we offer patients, such as steroid injections or surgery. Some of the common adverse events that we see with injections of any kind are soreness for a few days after injection, and that's true also with injection of PRP or some of these other biologics, but it's usually self-limited. Next slide. Our friend Dr. Centeno, who founded a company called Regenerative, actually published this paper, 2,300 plus patients studied for more than 8 years, showing that there were no serious adverse events, no safety issues when using bone marrow cells. Another one of our colleagues, Dr. Philippe Hernigau, who's an orthopedic surgeon in Paris, who really is a pioneer in this field and has been using bone marrow derived stem cells for almost 30 years, published this nice paper where he followed his patients for more than a decade, showing that there was no increased risk of cancer. And he followed these patients very closely with repeat MRIs and X-rays for years. And then also with adipose tissue, with fat tissue, we've also seen a very good safety profile. Adipose tissue has been used more recently, just within the last 10 years, I would say. And so we don't have long-term data, but we do have more than, it says 5 years there, but we're aware of studies that go out to 8 years without any serious adverse events. Next. Okay, so what's the evidence that these cell therapies are actually helpful in the spine. So I think Dr. Ambach is going to talk about this.
Let's talk about the science and the evidence for using these cell therapies in spine pain. And you've probably seen this slide in our previous webinars, but the research on platelet-rich plasma and other cell therapies have really increased, especially within the past 10 years. And the same is true with stem cell research. The data on the use of these cell therapies for spine pain has not been as extensive as, for example, knee osteoarthritis or tendon injuries. However, the early clinical research for the use of cell therapies for spine pain have been very promising and have shown really great potential. We are also using the data that has been published for joints and tendons and ligaments in the extremities in guiding our treatments for treating spine pain. For example, there's extensive and robust data on knee osteoarthritis, which we used to help us guide with regards to treatment for arthritis in the spine, for example, or ligament injuries in the extremities. Data we used to treat SI joint ligaments or laxity in the joints that are closely related to the spine. Same is true with nerve injuries in the extremities like carpal tunnel. For example, we use those data to treat and guide our decision-making on treating sciatica or nerve injuries in the back. So there has been scientific research on using PRP for patients with sciatica or that nerve irritation that's coming from the back. And the PRP does this by several mechanisms. It enhances nerve repair, it improves the blood supply to the region, and it also reduces inflammation. So I always tell my patients the PRP is like a safer and long-acting cortisone that is actually not harmful to your tissue. PRP has also been shown that it improves pain in patients with low back pain due to degenerative discs. And in this study, they were able to show that the patients are able to do their daily activities without the use of pain medications. So it's considered to be a good alternative for steroid injections, like epidural cortisone injections or even surgery. There's also data to suggest the use of PRP improving pain and function for patients who have facet joint pain or these little joints that connects the small bones in the spine. They've shown that it lasts longer than cortisone and local anesthesia, and it results to better disability and better patient satisfaction in patients that receive this treatment. And as I mentioned earlier, the use of PRP for sacroiliac joint pain or SI joint pain has been studied as well. And the use of PRP has improved pain and function more significantly in these patients that were treated with PRP rather than cortisone. So if you look at the graph on the right side of your screen, you can see that the steroid injections into these SI joints decrease the pain by 25%. However, PRP decreased the pain by 90%. So there's a significant difference in the outcomes. They have also shown that there was no serious adverse events using PRP for these procedures. A lot of the data for using cell therapy for spine pain has been focused on disc degeneration or injuries into the discs, which is that cushion in between the bones in our spine. And there's preclinical data that suggests that it works in different mechanisms. They've shown that the cell therapy can increase the water content or the hydration in the discs. As we know, these discs are gel-like materials that acts as a cushion. And over the years, we can lose some of this water and makes our discs more dry and makes it more prone for injury or what we call annular tears, or these small tears in the discs. It also decreases inflammation in the spine, It increases support tissue in the discs. And we have seen some studies that after injection of this cell therapy, the annular tears or these small cracks in the disc have actually resolved or improved. And lastly, these cell therapies promote a healthier environment for the spine to repair itself. So this is one such study where they injected the PRP into patients who have low back pain because of degenerative discs. And the results showed that the PRP did improve the patient's pain, function, and even their satisfaction in getting the treatments. So all of the pain of the patient, whether it's their current pain, their best pain, or their worst pain, as you can see on the graph on the right, all of this pain has been decreased significantly after PRP treatments. This is a study particularly using a bone marrow stem cell therapy for degeneration in the discs. And they have shown that just like PRP, it also improved the pain and function in these patients who have this problem. They have also shown that when they took MRIs of these patients that received the treatment, 40% of them had improvement in their discs at 1 year when they repeated these MRIs. So if you look at the MRI picture at the bottom of your screen, the arrows are pointing to the degenerative disc on the left there, which is letter A. And after treatment, if you look at picture B, you can see there's more hydration, or there's more lighting up of the discs at L4 and L5, are represented by the two arrows. The patients that they enrolled for these studies were all candidates for surgery, specifically artificial disc replacement or fusion. And out of the 26 patients that were enrolled in the studies, in this study, 6 of the patients underwent surgery. And when they continued to follow these 6 patients who underwent surgery, they followed their disability and their pain scores, and it was found that it was no better than these patients who did not proceed with surgery. The results of this particular study were actually better in outcomes when they compared it to the outcomes from patients who have undergone surgery in general from artificial disc replacement or fusion. This is a study that we have published about a year ago, wherein we studied the use of PRP and bone marrow cells for degenerative discs. And we have found that 93% of the patients that were enrolled in the study had improvement of pain of at least 50%, and it also improved their function. We didn't see any adverse effects. And more importantly, a lot of the patients, 80% of them, decreased their medication use. All of the patients who underwent treatment with these cell therapies did not have any hospitalization, any ER visits, or any surgery throughout the time that they were enrolled, and even after. So this is another ongoing study that I'm currently a part of. And this is a multi-center study across the US. There's 4 sites that are involved. And we are planning to enroll a total of 60 patients. And the goal of this study is not only to study the use of these cell therapies for degenerative discs, but we also want to compare head-to-head the results of PRP and bone marrow on degenerative discs, and to find out which is better, or for what clinical indications they would work better for. So the preliminary results of these studies have been presented at a recent conference, Regenerative conference, and so far the results have been very promising. The patients that I enrolled in our site, which is a total of 15 patients, were anywhere from the ages of the mid-20s to mid to late 60s, and they varied in occupation from being a jiu-jitsu player, or a firefighter, a dentist, and a student, and all of them did really well, at least in the site that I enrolled. If they're not doing well, they have at least maintained their status quo. And this is at 6 months so far that we have the data. So it will be interesting to see how they would improve in the next 1 year when we do our follow-up outcome study for them. So what other orthopedic conditions can we treat with these cell therapies? If you have attended our other webinars, you're already educated on this portion. We know that PRP can work really well with patients with knee osteoarthritis and tendon injuries like tennis elbow, which is the elbow irritation in your in the outside portion of your elbow, tendinopathy or tendon tears in your buttocks or the gluteal region, patellar tendinopathy in the knees, rotator cuff tendinopathy in the shoulder, and plantar fasciosis in your foot. There's also the use of bone marrow and adipose-derived cells for, again, joint osteoarthritis, and usually we tend to favor these therapies for moderate to severe osteoarthritis. They also work well for soft tissue injuries like Achilles tendinopathy, different tendon tears like I've mentioned, ligament tears like ACL tears in the knees, and other bony injuries. So we didn't have time to discuss how these cell therapies are prepared, but we have slide presentations with detailed information on how we prepare these therapies in our lab, in our clinic. And if you can check out our YouTube channel and search our name, San Diego Ortho Biologics Medical Group, you can avail of these slide presentations. So this is a very timely information. I know this COVID pandemic has affected us in many ways. Johns Hopkins University, their Department of Orthopedic Surgery did this study, and they wanted to see the impact on this pandemic on the elective orthopedic surgery. And they have found that it will take 7 to 16 months, so about a year on average, for the healthcare system to reach most of their cases, 90% of their expected forecasted volume of orthopedic surgery. So we know that treatments are going to be delayed, especially the elective cases, surgical treatments. So we will need more than ever more options for effective non-surgical treatments to manage our orthopedic problems. And this is where innovative treatments like cell-based therapies that can provide long-term relief and can actually heal injuries are more important more than ever. Not any healthcare provider can provide PRP or stem cell therapy. You want to select physicians who are specialized in diagnosing and treating orthopedic orthopedic conditions. And these typically are in the specialty of physical medicine, orthopedics, or sports medicine, and other similar specialties. You want to seek physicians who are actually experienced in using guidance in performing this procedure using ultrasound or live x-ray or what we call fluoroscopy. And you want to seek physicians who are skilled in not just performing the procedures with this image guidance, but also who know what cell therapy is best for your specific injury. And you want to seek clinics that perform treatments that are FDA compliant, and most importantly, who are committed to excellent outcomes and excellent patient care. So speaking of providing the best care and giving patient-informed medical decisions, we use this regenerative medicine registry. It's called Data Biologics. This is co-founded by Dr. Rogers. And it is a very easy cloud-based registry that we use in our clinic to track our patient outcomes. And it also can give us real data to present to our patients to show them how we're doing with the therapies that we are providing in the clinic. And not only does it track our outcomes, it's also useful information for insurance companies and regulators to give them a guide on the future decision making process on what will be covered procedures or not. So that ends our lecture. Thank you everyone for staying with us. And we hope we have answered a lot of your questions. And for those that we haven't, we have a question and answer portion right now wherein we can take each and every question that you have written for us and we can answer it to the best that we can.
If you look at the bottom of your screen, you'll see it says Q&A on the right. If you click on that, it should give you the opportunity to enter your question. The first question here, it says, can MSC cells rebuild myelin like for patients who have multiple sclerosis? So the first comment I'd like to make is we are orthopedic specialists. We are not neurologists, so we don't treat patients with multiple sclerosis. And that comment is relevant because if you Google stem cell clinic, you'll see many clinics that pretend to be doctors of all things. They are your dermatologist, your neurologist, your orthopedic surgeon, and your cardiologist. And we know that that's just not possible. So as it is, Dr. Ambach and I spend our entire life reading articles in orthopedics, and that's just enough to keep us busy. So we are not experts in multiple sclerosis. Nonetheless, I have read a few articles about multiple sclerosis, and we know some researchers in Australia who are researching the use of stem cells for the treatment of patients with multiple sclerosis. In short, it's a complicated disease that involves your immune system attacking the lining of your nerves in your brain and your spinal cord. And the lining of those tissues is called myelin. And yes, there is evidence that stem cell therapy can be helpful for patients with multiple sclerosis. But I think the take-home message will be, sorry, we're not FDA approved yet, although there are people working on that research, and hopefully someday we will have a successful treatment for patients with multiple sclerosis, and it may just involve cell therapy.
I just wanted to add, Dr. Rogers, there has been some animal studies that have shown that platelet-rich plasma or even cell therapies can actually promote axon growth. Axon is this nerve fibers that connects your nerve cells, and it transmits electrical impulses. And that's why some of these therapies like platelet-rich plasma can be useful for localized nerve injuries like carpal tunnel syndrome, and that's how they can help sciatica as well. But to Dr. Rogers' point, multiple sclerosis or other systemic neurological injuries is something that is unknown at this time. So next question, does your stem cell therapies replace the need for back surgery or complement it before or after? So you have a question about degenerative discs and was told that fusion back surgery is the only thing that works. So there's many reasons for surgery, right? The main indication for surgery is one, that they have failed conservative measures, and two is if there is severe neurologic injury in the spine and causing weakness or debilitating pain or unstable spine. And these are indications for surgery. However, a lot of the causes for spine pain that we see or that is prevalent in the community are actually non-surgical. And there are many causes for spine pain, and we just presented some, but there's a lot more that's causing spine pain. And these cell therapies have been actually, in our clinical experience, have been very helpful in treating the patient's pain and function that can last for anywhere from 1 to 3 years or even longer. So yes, there is a possibility that these cells, and we have seen it in clinic, can actually either replace the need for surgery or even give you the time to keep you more functional and decrease the pain while waiting for an eventual surgery down the line if need be. So really good data, especially on disc degeneration, which is what I'm pretty excited about, because right now there's really no treatment for tears in the discs or degeneration in the discs that can actually heal these injuries. And right now, the surgery indications for disc pain, and what they do is they either just fuse you or put a hardware in your spine, or take out the portion of the disc that's bulging, or even replace the discs itself, which is very limited in its indications. So it doesn't really address the problem. So this is very exciting for cell therapy to treat disc degeneration. It can very well change how we treat this orthopedic injury in the future.
I think I'd like to add, having worked side by side with spine surgeons for more than 20 years, and I have the utmost respect for them because the work they do is very challenging. one of the challenges of treating a patient with back pain with a surgical procedure is we are oftentimes limited in fully understanding the nature of that patient's pain. So again, if I pull my friend here, the skeleton, there are a lot of things in here that can go wrong. Each one of these discs can be a source of pain. Any one of these 10 joints in the back can be a source of pain. That's just getting started. We're not talking about muscles, tendons, ligaments, or all the little nerves that come out of these little holes. So it's very important that when you consent to surgery, that your surgeon truly understands the nature of your pain. We know that it's not sufficient to look at an MRI, like many clinics do. They won't even examine you. They'll just look at the MRI and they'll say, well, you've got disc degeneration on your MRI. Let's fuse you. That's really, in 2020, that would be malpractice. And yet spine fusion is still extremely common. If you look at spine surgery, spine fusion in particular, most of the studies will show the success rate is less than 50%. That is a coin toss. And that is a crime. It is unfortunate that someone undergoes such a major surgery that has a long recovery, high expense, and is potentially harmful to have such a low success rate. So in order for cell therapy to be shown to be as effective as a spine fusion or more effective than a spine fusion is really a very low bar to achieve. So we're confident that once these studies are completed, we will be able to demonstrate that, and Dr. Ambach's already contributed quite a bit, as you heard. But I'm not anti-surgery either. Matter of fact, I just referred someone to a surgeon this morning because that patient does need surgery. And so we understand there's a role, and it's really just a matter of providing the right treatment for the right medical condition. The next question is about a condition called pars defect. And so the person who submitted the question knows, but the rest of you may not know what a pars defect is. There's a little area here in the spine. It's hard to see, but between the joints is called the pars. Some people are born with a defect in the bone. Other people may have fractured the bone. This can result in instability of the spine. And the pain with a pars defect can come from many different places. It may come from the defect itself. It may come from the joints, which are now arthritic because the spine is more mobile. It may come from the ligaments or tendons, and it can also come from the discs. So again, as I told you at the outset of this presentation, I've never seen two patients exactly the same. And it really is incumbent upon us as your physician to do a really good job of doing a great physical exam, listening to your details of your history and symptoms that you're having, to review the imaging, if necessary, order more advanced imaging to further evaluate. In some cases, we inject local anesthetic into different parts of the spine using X-ray to guide us to see if we can alleviate the pain and identify the source of the pain. But in your specific question about pars defect, there is some published literature showing that in a subacute pars defect, the use of a bone marrow concentrate injected into the defect has been shown to be efficacious. And while I myself have not seen that patient, I'm familiar with the published literature, and there's been actually a number of cases that I'm familiar with where that's been the case. But I would say it's more likely that the pars defect is not the cause of the pain, and our job is to figure out the cause and provide a treatment option that makes the most sense.
So to piggyback on that answer, Dr. Rogers, that will it's also related to this next question, asking about chronic neck pain and upper shoulder spasms. What does our specialty do for these conditions? And the answer to this is it depends on where your pain is coming from. Again, we have to put on our diagnostic hat and try to figure out where your pain is coming from. Is it coming from your discs, from your joints, from your nerve? Is it coming from your soft tissue, the muscles and the ligaments around your spine? And we can treat it accordingly. And we do have a lot of treatments for this depending on what the injury is.
It just in a nutshell, spasms are often treated as the enemy. They're not. They're your friend. The muscle is spasming because your body is detecting instability. So if a ligament, for example, which normally holds your bones together, is injured, your muscle will spasm to protect the instability. Or the other thing that can happen is if a nerve is irritated, you can have a muscle spasm. So it's our job as your doctor to identify the cause of the spasm and treat the cause, not the spasm. And then the next question is, what about spinal stenosis? So spinal stenosis is a condition where, again, going to our friend here, if you look on the side of the spine, you see these little holes. and nerves come out of those holes, and those nerves will go into your leg. There's also a big hole in the middle of the spine called the central canal, and that's where, you know, all the nerves are traveling from branching off of your spinal cord, which, by the way, ends about here. So your spinal cord runs from your skull to about here, and then at the bottom of the spinal cord are about 14 little nerves that will come down and exit out through those holes. So anything that would impinge on that space, anything that might pinch that nerve, we call stenosis. And just like anything in life, there's different shades of gray. There's mild stenosis, which is very easy to treat with PRP injections in the epidural space. More severe stenosis, I find that in my patients, more often I'm referring that patient to a surgeon to have a decompression because the success rate is going to be higher. So our job is to identify when to be conservative, when to be aggressive.
Next question, are any treatments cited today authorized by Medicare? Currently, these treatments are not covered by insurance. It will change, and that's our hope, and that's why we're trying to engage in several clinical trials to hopefully garner more information and present it to the insurance companies, but currently they're not covered. There are some work comp cases that are covered, or maybe in the military, or companies that have their own insurance can cover for this, but PPOs and Medicare do not cover for these procedures at the moment.
And we used to think it was because there wasn't enough evidence. We'd say, well, these are innovative therapies, they're investigational, we haven't conducted randomized clinical trials. But in the case of PRP for knee arthritis, we have better evidence for that than almost anything in medicine. We have more than a dozen meta-analyses, which is the highest level of scientific evidence you could imagine for a therapeutic procedure. And yet it's still not covered, with the exception that Dr. Ambach mentioned. We are seeing companies that are self-insured, so smaller companies that supply health insurance to their patients, to their employees. They are realizing the cost savings of treating with these non-surgical procedures. And I think they're going to lead the charge. And I think it's only a matter of time before the PPOs and eventually Medicare see the light and realize that the therapeutic treatment options that have been shown to be safe and effective should be covered by your insurance. This question, do you recommend an inversion table for those with an impinged nerve in the neck? How about neck traction gadgets and things like this? So I'm finding that traction, which is where you're trying to stretch the spine and take the pressure off those pinched nerves, it's a double-edged sword. Some people do fantastic. I actually had a herniated disc in my neck about 10 years ago. There were days where traction was fantastic. There were other days where it would flare things up. I think it should be done under the supervision of a skilled physical therapist. It can be a successful but probably temporary treatment option. Sometimes it's just useful to get you over the hump and get you past the acute inflammatory phase. With inversion tables, they are helpful. A lot of our patients use them. There are contraindications that you should be mindful of. If you think you're at risk of falling off of that traction table, you probably shouldn't be on it. Actually, I had a patient build one himself, and then it fell apart, and he needed me for some other reasons after that. So be careful. If you have hypertension, that's a contraindication to using traction. If you have glaucoma, that's a contraindication. But I would say, by and large, it's a safe treatment option for most patients with spine pain.
Next question, if you had positive outcomes treating lower lumbar pars defect on average, how long does the relief last? My clinical experience with pars defect, upon evaluating the patient, the pain was actually coming from his facet joints, because when your spine is out of alignment, you're putting a lot of pressure and tension in these joints. And over the course of time, they get inflamed and they become arthritic. So when I treated the facet joints with bone marrow therapy, in the process, I also treat the supporting ligaments and peppered some of the therapy into the pars defect. It lasted for him for about 2 to 3 years with good function, which means he was able to return to work. So in the clinical literature, it's the same, wherein if you do these therapies for the spine, whether it be joint or nerve injuries or discs, typically it lasts anywhere from 1 to 3 years or even longer in some patients.
It depends on the nature of the condition, of course. So if you, osteoarthritis is a chronic degenerative condition. For years, we would tell folks, well, arthritis is a wear and tear of your cartilage, and that's actually not true. Osteoarthritis is a condition where there's a chronic inflammation in the joint, which makes it difficult for the cartilage tissue to survive. And so over time, it thins and degenerates. And so as of this date, nothing on the planet can halt osteoarthritis. We're all going to get older and we're all going to get osteoarthritis, but you can mitigate the symptoms of the osteoarthritis. You can decrease the inflammation, decrease the pain, and in some cases, yes, regenerate enough tissue to get a few years relief. And this is something that really we haven't been able to achieve with any other form of medical treatment, including surgery. As you know, surgery does not repair or restore the joint. It simply removes tissue that's painful, typically. So that's a really exciting aspect of cell-based therapy, is the notion that we can actually treat and heal tissues, and in many cases, and I think the success rate will be higher if we can catch people earlier, right? Stitch in time may save 9. So an earlier treatment, catching a condition when it's more mild, we're going to have much greater success. And I have many patients who I treated more than a decade ago who are still doing well because we caught them early. Now, there's a couple of questions I see here about artificial disc replacement, and San Diego is home to a team of very talented surgeons who conducted a lot of research in this area and were pioneers in the field of artificial disc replacement, which was an alternative to fusion. So instead of putting rods and screws in the spine to hold the bones together, instead the idea was to keep the motion of the spine by putting an artificial disc, just like you would put in an artificial knee or a hip, so that this disc, which was degenerated, could be removed and then replaced with a titanium component that was mobile. The problem is you still have all these other parts in your spine. So just because you had a very successful disc replacement doesn't mean that the rest of your spine cannot degenerate. The hope was that having preservation of the motion, there would be less propensity for the adjacent segments to degenerate. We know that when you fuse the spine, there's a much greater risk that the levels above and below could degenerate because of the extra stress placed on them. But we're really not seeing the benefit that we were promised years ago from an artificial disc replacement. We still see patients getting arthritis at adjacent areas. So it's almost a moot point. As long as the surgery was done properly, and we're convinced that that's not the problem, it's very likely that pain is coming from another level. And many times it's the disc above or below, and it was just missed, or maybe it was a small tear that was not symptomatic and now has progressed to become a bigger tear in the disc. So that's something we see very often.
Next question, can you detect injury in your office without having an MRI? That's yes and no. We do our clinical evaluation in the clinic. We do have imaging guidance, and most of the cases of spine problems, we form a plausible diagnosis just after evaluating you and examining you. However, MRI does help in looking at the structures in your spine, specifically the discs and the nerve roots and the soft tissue that we can't typically see in a regular x-ray, for example. We also have seen patients who have MRI findings that does not correlate with their symptoms. So it goes together, the imaging findings and the physician's clinical evaluation goes hand in hand and is both important in diagnosing a patient properly.
Dr. Ambach, I'm going to tackle the last 4 questions here because we're almost out of time.
Sounds good.
There's a question about the thoracic spine, which is the part where your ribs attach in the middle of your body. We treat those very similar to how we would treat your neck or your low back. There's really no difference there. The other question is about using it for osteoporosis, which would be thinning of your bone. We do not use stem cell therapy or PRP for osteoporosis. Osteoporosis is generally not painful unless there's a fracture, in which case there may be a role in the future, but currently we don't use cell therapy for fractured osteoporotic spines. Supplemental collagen or anything that you could eat, a pill or a supplement that's been shown to be helpful for back pain. I'm currently not aware of anything that's been shown to be definitively helpful. so we don't use those types of products. And the last question that I would like to address is something that I'm very excited about, and that is there any research or promise for the use of stem cells to treat patients with COVID? And as you know, we currently do not have a treatment in the world that has been shown to be effective for treating patients in the hospital with COVID, pneumonia, or respiratory failure. And I am involved with a company who has obtained FDA approval to use stem cells obtained from fat tissue, which will be injected in the form of an intravenous transfusion for patients in the hospital. And we hope by next month we'll have treated our first couple of patients, and we'll hopefully have some really great news to report to you. There has been promising work done elsewhere in the world, in Spain, in Israel, and in some early studies, even in New York, there's been shown promise that cell therapy, when done properly, can actually mitigate the effects of the inflammation that occurs in the lungs. Because as you remember, these stem cells are anti-inflammatory. The other exciting thing is that research will dovetail into some other research that we will be doing for patients with low back pain, where we will develop new orthobiologics, higher doses of stem cell therapy, tested for sterility, that can be injected into the disc and into the joint. And we'll let each of you know when we start those clinical trials, which should be before the end of this year. I'd like to thank all of you for your attention, for joining us. If you're interested in visiting us, you have our contact information there on the screen. And I just wish all of you the best. Stay healthy.
Thank you.